Good evening and welcome to our educational webinar on Lapiplasty 3D bunion correction. We appreciate you joining us. I'm Kendall Rock, social media specialist at Treece Medical Concepts. Treece Medical is the company who's patented the Lapiplasty procedure and manufactures its instrumentation and implants. Our goal here tonight is to provide you with the quality information because we know that making a surgical decision is a decision that isn't taken lightly. We applaud you for empowering yourselves with information to make the best informed treatment decision you can. I will quickly get a couple of housekeeping items out of the way so we can get right into the presentation by our surgeon speaker, Dr. Togan of Canton, Ohio. First of all, you are listening to the webinar on mute, but you can ask questions throughout by clicking on the questions tab in your control bar and typing them in. We'll be answering questions sprinkled throughout the presentation and at its end. We'll also be emailing you an archived link of this presentation to refer back to within just a few days. Lastly, I know that you will enjoy our speaker, Dr. Togan, but if you are attending outside of Ohio, you can find locally trained Lapiplasty doctors in your own area to consult with by visiting our patient website, lapiplasty.com. There is a prominent Find a Doctor button at the top of the homepage, searchable by zip code. With all that out of the way, I'd like to introduce tonight's surgeon speaker, Dr. Togan.
Thank you very much for that presentation. I wanted to obviously get started. Kendall, can I move forward on the slides?
Yes, you can.
All right. So, everyone, thank you all for joining. It's a exciting time here, especially working through the Lapiplasty. So, working through a few things in the slides. Lapiplasty, as you know, is a surgical procedure. Only a surgeon can tell if Lapiplasty procedure is right for you. We'll go over many things with bunion correction, and all the great things that it's best to work through with the Lapiplasty correction. As I've been doing this now for about 3.5 years, been in practice 21 years, and have really seen how amazing the procedure really works for patients, how happy they are. So this experience is unique, specific to the patient only. Potential risks include infection, pain, loosening, loss of correction, improper bone healing, and we'll go over most of these in general. This is my intro, if you will. Again, running 3 locations, talk about most of my qualifications, and again, I run a fellowship for residents and others that are wanting to do more training with larger procedures, especially learning more about the Lapiplasty correction. So the Lapiplasty system was FDA cleared since 2015, but essentially this is not an investigational device. These are items that they have done much research and still doing research on, as our office is part of one of the studies through Treece Medical. It's a patented procedure. It's manufactured by Treece Medical Concepts. Requires advanced training. It's not offered by all surgeons. It's definitely a certification, just as though we would do certification through other types of surgeries, arthroscopy, ankle replacements. And again, not all surgeons are interested in this. What's funny is that I have patients come from all over. I've had patients come from Arizona and South Carolina that have come to us to have their procedure performed. And they kind of ask why not everyone's doing this, and I don't have an answer for them, except that a lot of times surgeons may or may not be comfortable in this situation or do not want to undergo the 3D correction for a 3D bunion procedure. So what's exciting is on April 16th recently is that they had National Bunion Day, and just most recently they've completed over 100,000 patients have been treated with the Lapiplasty system. It's covered by most insurances. Medicare cost and coverage vary. Need to check with the provider and find trained surgeons at this site, www.lapiplasty.com. With any surgery, there's always a chance for some form of complication, such things as infection or adverse reactions. In my experience, There have, even with procedures that some people do get a superficial infection. Some have issues with hardware. Hardware or the plates and screws are only in there for one reason, and that's to get things corrected, maintain correction and fusion. And then at some point, the hardware may or may not serve a purpose. Just with even an ankle fracture, once it's corrected the position, it doesn't need to stay in the body. Pain and discomfort, abnormal sensations. Some people do get some nerve sensations that I've seen in my practice. Loosening, bending, cracking, or fracture of the components. These are all things that can be complications. As you know, surgery does come with complications. It's best that the patient follows through with the postoperative course to minimize these complications at best, as we do everything we can to surgically keep everything sterile and to allow the best outcome and the most efficacious outcome for the patients. So bunions, for people that know or not know, we need to learn a lot about bunions, and some people in the world today are able to research this and know a lot more about their problem or their deformity before they even come in the office. So bunions, it's not just a bump. It includes pain, swelling, pressure, numbness. There is a nerve that runs right by the big toe joint. That is a problem source of where people will complain of numbness to the tips of their toes, when it's essentially the bone pushing against the soft tissue, which then entraps the nerve and therefore getting numbness to the big toe. Worse is toes are crowded, standing for long periods of time. So when you see or look down at your foot, or those with a bunion can see that bump sticks out. Sometimes it is just soft tissue swelling of the capsule. Sometimes it is just bone deviation of the metatarsal. It's not really a enlarged growth of bone. The largest misconception is that a bunion is an overgrowth of bone that can be, quote, shaved off, unquote, but it really is not the root of the problem. The root of the problem is an unstable joint. The unstable joint is located at the tarsal metatarsal joint, which is down in this area down here, which is at the midfoot. That's where the instability arises, in which patients do have a large amount of hypermobility or overactive joint, which then causes ligamentous instability, and therefore the bunion starts to form. Most of the reason you come into the office is then to get x-rays. The number one thing we would do is looking at 3 different films, which is a top view, a side view, and then the most important are these sesamoids. These are small bones that are actually the size of your thumbnail. The largest sesamoid in your body is your kneecap. These are essentially the bones that ride underneath the big toe and the metatarsal to protect tendons and other types of structures. But what's happening is the bone deviates towards the inside of your foot or towards the inside of your arch. Those sesamoids will move towards the second metatarsal or towards the outside of your foot, thus creating pain, and then the bunion forms from that reason as the 2 tendons start to act against each other and therefore create instability. So this unstable joint in the middle of the foot, as we talked about the tarsal metatarsal joint, causes the bone to drift out of alignment. And as we talk about footwear, the misconception was that you're wearing too tight of shoes, which can aggravate or accelerate the condition, but it's mainly due from a genetic predisposition or a biomechanical imbalance, which again kind of leads down to the genetic predisposition, as someone in the family may have had these when they were younger or older, and then the next generation could get this. So I've seen bunions in my practice of patients who are as young as 15, 16 years of age. I've actually seen bunions even with children younger than that, in the 12, 13 range. But in order to perform the Lapiplasty for these procedures, they do need to be where the bone has healed back in the area here in order to perform the procedure, which again is the best procedure out there to correct the bunion procedure. Bunion treatments, the traditional 2D osteotomy, which I've been in practice for years, that was which way we were trained. But at the same time, I was also trained to do the Lapidus, which is the procedure that is back in the back here, as we now have the Lapiplasty procedure in order to help achieve the Lapidus, which is then the fusion at the base of this first metatarsal. So what's been the main thing is that why take a straight bone and break it or make it crooked when it's really just the idea that you can actually push it back over just like a leaning tower. So you can see this tower is leaning. Why correct it at that deformity when you can just push the entire area back over, back into alignment, fix the unstable foundation, and create then a stable foundation. So this is a large part of the procedure back in the day, is people would come in, have an osteotomy, or they'd shave the metatarsal off from other surgeons, and then actually 6 years later or less, it could come right back, and people were having more of a procedure done, which again would create more problems because now it's a bent bone and you're trying to correct a bent bone instead of a straight bone. Non-surgical treatments, which can be done as patients have come in and tried. In my practice, these treatments are there to kind of keep you comfortable. It doesn't actually correct the problem or correct the root cause. There are such things as toe spacers, pads and splints, inserts and orthotics, which a patient came into the office and said, hey, I'd like to talk to you about the bunion. And then we start with orthotics if we need to, padding and splinting. And again, a lot of this goes down to the fact that the patient has to try at least a few number of conservative treatments before they can just have surgery in order for insurances and other things to be able to cover these things. Plus, not everyone has to have a bunion corrected. And in my experience with this procedure is I don't have to worry about it being a mild, a moderate, or severe bunion. In my category with all patients, it can be treated for any type of bunion, mild, moderate, severe, of any severity, and it still gets the best correction I've seen. So how it works, as we know, it's the 3D bunion correction. It is patented. The entire bone is returned to normal alignment. Natural anatomy is returned. The straight toe is back, rotated back into position. So as we know, I talked about getting three different types of x-rays, a top view, a side view, and a view of where it shows the sesamoids. So that's, again, the three-dimensional, that you need to switch this and push this into three-dimension. There's a frontal plane, a transverse plane, and a sagittal plane deformity, which are the three planes in which the bunion is fixed in order to get it back into position. Therefore, making a straight bone, correcting the stable foundation or the unstable foundation, and pushing it back into place, and then holding it in place with plates and screws. So a few questions that we can at least look over for some patients that, again, I went over a few of this, but looking at this one, how do you determine if a patient is a good candidate for Lapiplasty? Really, I've had patients come into my office and they know so much research, and they walk in and say, well, I'm here because I want to have the Lapiplasty done because they've looked up everything. And there are some patients that don't even fit the mold for a Lapiplasty. They might have what's called a hallux varus, in which the toe is completely in the other direction and not a hallux valgus. And therefore, it's best to have a consultation with the surgeon. We're happy to have you come in. We're welcome to look over your x-rays, the consultation. We look for instability. We check the range of motion of the great toe. We look at your foot. There are times that patients need a flat foot correction along with the bunion because there is an association of needing more than one procedure than just having the Lapiplasty procedure. So it does entail knowing the root of the cause. If it is a flat foot deformity, it's best to correct that along with the Lapiplasty correction. So there's a lot that goes into the consultation and recommendation by the surgeon who does the 3D correction. My bunion is moderate, severe. Is there a bunion so severe it can't be treated? Well, as I talked about before, I do think that any bunion now in my practice and in my hands, that I think that even the smallest of bunion to the largest of bunion, to me, it's the same procedure. We go into the operating room. It's an outpatient procedure. We make the incision. I now can make an incision that is only 2 centimeters big when I used to have to make them 9 centimeters large in order to correct this type of procedure. Now we can do it in a very small incision, same correction, reproducible every time. I walk in knowing that every time this patient has this procedure, it's going to be the exact same procedure. It fixes all severities, mild, moderate, severe. And again, it doesn't change in my practice at this point. So can you get it if you've already had a previous bunion procedure? Again, what makes it difficult is if you've had a previous bunion procedure or if you've had a previous lapidus, which again is that same procedure at the tarsal metatarsal joint. Sometimes it is a reason to redo it. Sometimes they didn't quite get the rotation. The position never was able to hold itself into position. And sometimes these procedures don't unionize or they don't fuse together. So there are things such as a non-union, a malunion, a delayed union, in which the bone just doesn't fuse properly. And if it doesn't fuse the way it's supposed to within that 6-week to 3-month mark, there are times that the bunion deformity could possibly start to shift. And then these are patients that have come in to see me because they may have had the procedure done somewhere else and the area has returned. So it is definitely all about following through with the post-op course, being healthy, not smoking, treating everything the way it should, taking the time to heal properly in order to let this get the best outcome so that after 3 to 4 months, the patient can really return full activity with minimal pain at all. So how is it different? Of course, it corrects all 3 dimensions we talked about with the frontal, the sagittal, and the transverse plane. It does not cut or shift the bone. It is fixing the joint at its unstable foundation, addresses the root cause, gets you back in your feet and walking boots. In my experience, in my practice, I have had patients start walking in a matter of 3 days. I have started to place them more into a splint or in their boot and maintain a non-weight-bearing attitude with them for at least the first 7 days, as I've seen patients possibly may overdo it by letting them do things too early. Doesn't mean they're not going to get back on their feet anytime soon, but from my standpoint, it's best to let the skin heal before the bone heals. And once the skin is healed, I don't have much to worry about at that point. Then the bone should go on to heal. So in my practice, I do want them to stay off it a little bit longer in the beginning because I feel as though it gives them the best outcome in my experience. I've been, again, doing Lapiplasties for the last 3.5 years, and our center is a dual centurion, so we've done over 200 of these cases in a matter of a few months with patients being very happy. What's amazing with the Lapiplasty is I used to have people come in with bunions. You'd fix it. They'd look on the x-ray and say, yeah, it looks okay. And then they would be in so much pain afterwards that they just always say, I'm never doing the other one. Now with this procedure, people are more apt to have the procedure done, and some have been wanting to get to the next foot even before the other foot's healed, which we can't do that. We obviously need to wait for at least 3 months to 4 months in between before we plan the next one. So what happens if you don't treat it? Obviously, bunions are a progressive deformity, same as vascular disease and peripheral neuropathy. It can get worse. The toes can cross over. People can get what are called hammer toes. Arthritic changes can get worse. That's the largest part about bunions, is that the joint becomes very arthritic, which again can create a significant amount of pain, which at that point may need more procedures along with it versus just the straightforward bunion correction. Bone spurs, ball of foot pain, entrapped nerves, and again are a progressive disorder and do not go away on their own. So showing some before and after, as you can see on a few of these, this is obviously the corrected on the first picture, 7 weeks post-op. You can see the incisions that are made. This is about the 5-centimeter incision on the first picture. Same with the second picture. I personally am doing these in a 2-centimeter incision as we've been able to create different types of Lapiplasty procedures such as the micro or even the mini incision, which are certain surgeons who do the Lapiplasty have been trained on these to perform these in an even smaller incision to give patients the best outcome, let alone the best scarring at that point. So recovery. With most people, like I said, it's about 2 weeks is when within those first 2 weeks is when I let patients start to put weight on their foot. I do try to keep them off of it. It is somewhat difficult to have them off of it, but when I used to do these procedures, the Lapidus alone, they couldn't put weight on it for 6 weeks. So I think people are more apt to keep it down for 1 week. It does let their swelling go down, lets their pain go down, and really makes them feel comfortable and really makes them somewhat compliant to stay down and let everything heal properly. During the procedure, or when the way we do things with anesthesia is we do a block, so we do numb the entire leg so that it's numb for at least 24 hours after surgery. That does keep their pain level down. Most patients will probably get some pain medicine after, but I've even been working on patients just using Tylenol and ibuprofen if they're able to take those prescriptions on a around-the-clock basis to keep their pain levels down, which has shown, with studies that it does work. The next 4 to 6 weeks, you're in a boot. You are walking at that point. You're returning to light activities. Most people can return to work. If they are not having to stand on their feet for 8 hours a day, they can return to a light-duty job if need be. as long as they're able to wear a boot to work. And then the main thing is, again, with patients with bunions that I've seen is that patients are, type A personalities at some point. Even I've had a bunion correction in my years, but it's mainly about getting back to activity. They know they have a bunion, they know they need surgery, they know they're in pain, but when can I get back to my activity? So the number one thing is, when can I get back to walking? So usually at 6 to 8 weeks, closer to 8 weeks, is when you can transition back to comfortable shoes, start walking for recreation. You may limp, but you're not in pain. It's just a guarding reflex. A lot of patients do need to go to physical therapy. Along with this, I do start patients at physical therapy as early as 3 days. I've had patients start physical therapy. Our office has recently created a physical therapy protocol in which we've been handing out to other physical therapy companies so they can be in the know or understanding how to treat the Lapiplasty procedures, as not everyone does this and not every therapist knows how to treat this type of procedure. So at 8 weeks, I let people start to walk for recreation. The biggest thing, you'll have swelling in your foot for about 6 months to a year. That gets frustrating at times, but the main thing is that it does go away. The swelling will resolve over time, and you'll go back to most normal, not swollen foot after a while. And then 4 to 6 months, that's usually when they can start to run, jump, high impact, squatting, that type of exercise that they can do is usually at the 3 to 4 month mark. By 4 months is when most patients come in for their last x-ray when they see me, and really that's when I allow them to start going back to full running, full activity. Possibly they get into orthotics. They're really very happy it's been performed. They feel like their decision to do this was really the right decision, and it does take some time for them to, recover because, again, they're a very active lifestyle and having to take their time to slow down for this procedure. So that's kind of the recovery at this point for performing the Lapiplasty procedure. At this point, the big thing is about the insurance that we talk about at times. I will tell you that through my practice, even when I started doing it, I used to have conversations with multiple orthopedic doctors who serve on panels for insurance plans. And the biggest issue is getting things approved sometimes. Again, it's mainly about patients have to have some form of conservative care prior to being able to be approved for the surgery. This, again, is using the certain codes that we use for the Lapiplasty procedure, which, again, is for the bunionectomy codes. It's usually a medically necessary as patients have pain, deformity, arthritis, nerve issues, and, again, a significant deformity that does need to be corrected. And so I've gone through many panels, and I think we've taught a lot of insurance at this point how that these are not procedures that patients will ever get rid of. And so they're starting to see this as being a very acceptable procedure to get this covered through their insurance. And really, in my practice, I haven't had any in which they've denied anything at all. If anything, it's just about how we're coding things. So if the doctor determines that this is right for you, you can reach out to the insurance, but mainly the hospital covers it. We have it approved at 5 different locations at certain hospitals. There are other hospitals I've tried to get this approved at, and certain hospitals just won't accept it or they just don't understand how to bill it correctly. And I've really worked with hospitals over the last 3 years to get them to understand that it's a necessity to get in their hospital system for us to be able to give not only my patients in the north, my patients in the south, different places to be able to have their procedure performed.
Thank you very much, Dr. Togan. We've had several questions come in this evening. Thank you for the great audience participation. We'll do our best to answer most, if not all, the submitted questions now. If you haven't yet, as a reminder, you may ask a question by clicking on the Questions tab in your control bar and typing it into us. But before I turn your questions over to the doctor, I will start by asking a quick question that has come in repetitively during the presentation. So, Dr. Togan, in your experience, can a patient have both their feet corrected on the same day at the same time?
So that's a great question. And at this point, two things. Number one, the insurance, because of the certain codes that we use, or at least the code that I use for the procedure, the insurance, number one, will not allow it to be done at the same time, as they know that that is a significant procedure to have done, and that the frequency limit is only one at a time to be able to have that done. And then number two, to be able to do both is somewhat difficult, because sometimes I feel as though you need to have one good foot, one bad foot. And to be able to get around on two bad feet, it doesn't really allow you to rest as much as I would like you to. So at this point, no, we don't perform both at the same time. It is kind of a hassle. I've had patients have theirs done as quickly as 6 weeks after the first procedure. In my experience, the best, I think, is you give it at least 3 months. So 3 months is when I would probably start to look at doing the second one, but not at the same time.
Thank you. Another question that has come through is, if my feet currently do not hurt, but I have bunions, should I still have the procedure done?
That to me is one of my favorite questions, because if you look so my big thing is that patients will come in. Recently, I just had a lady today who has a bunion. She's not in that much discomfort. And back in the day, if someone came in and said, I have a bunion, it doesn't hurt me, I would probably tell them, go ahead and wait, because I think a lot of us do understand that people out there still have bunions. They don't have any pain at all. The bunion doesn't bother them. But I'm more apt on the side of where I want patients to be able to have a long life of not being able to worry how bad this bunion's going to get, because again, the bunion can create hammer toes and problems. And the worst part that I can see is when patients in their 70s, 80s who come in and they have horrific bunions and toes that are all over the place and dislocated. Why? Because they never hurt before and they never got their bunions corrected. But in the end, I'm on the side of why not get it corrected so that longer time in life, you don't have to worry about these other deformities causing where they can't wear shoes they want to wear. They have pads all over their toes because it hurts so much for them to wear a regular pair of shoes. So it is tough to say, do I have it done when I don't hurt? I definitely would say if you don't hurt, it's probably not the right thing to do, because we're going to, end up giving you pain. But I mean, if you want to finally have it done, to know that long term in life, you don't have to worry about things getting worse, and you've seen maybe your parents' feet or grandparents, I think it's still best to get it done. Plus, if you wait or not, it's still the same procedure for me to get it done. So I guess that's how I feel about that question.
Thank you. Another question that's come through quite often is, can you elaborate on the recovery time and what that looks like, especially those first 2 weeks post-operation?
Sure. So in my practice, we even have a passport that we hand out to patients when they come in that gives them the full explanation in regards to the beginning to the end. So it usually starts out, patient has their surgery, they go in, they have the anesthesia that does the block. They then will be put probably into their boot with a soft dressing. So I've been kind of switching over to either putting them in a cast or a splint. Not everyone does well with a cast, so we try to make it very easy. The dressing stays on until your appointment. I usually call my patients 1 to 2 days after surgery, even on the weekend. We do need to, make sure they're doing well. And then usually they come in to see me 7 to 10 days later. If it's your right foot, you cannot drive for 2 weeks. If it's your left foot, you can drive as long as you can maintain non-weight bearing getting in and out of the car. But sometimes it's best to have someone be with you for your appointments if necessary. But after you come in to see us, we'll take the dressing down. A lot of times we'll put you back into a wrap, which is essentially a compression wrap that goes from your toes to your knee, because the more we squeeze or compress the swelling out of there, the quicker your healing will be, the better your incisions will be, the less complications. And then by 2 to 3 weeks is when we either take out stitches if we have to take them out, or sometimes they are just absorbable sutures and we don't have to take those out. And then normally after those 2 weeks, again, after the first appointment, we usually let you get up in the boot. And again, not everyone can place their foot on the floor. Sometimes it's too uncomfortable for them. So everyone recovers differently, but normally at those 2 weeks, you can start weight bearing in your boot, getting around. And then once the stitches come out and I feel like you can shower and get it wet, then you can probably get the foot wet, wash it. And then after that, it's all about keeping compression on there as it goes on to heal.
So if I had a bunionectomy in the past, am I still an eligible candidate for this procedure?
You are. The number one factor is going to be how much arthritis is in your joint. So if you end up having a 2D procedure and the incision is over top of your great toe joint, then at this point there's a chance that the arthritis may be too great. The bunion has returned. But at this point, you would end up having the Lapiplasty, but you would have to have another procedure of your great toe joint, which is either another Lapiplasty, because we now can use Lapiplasty for numerous joints in the foot, or you have both the bunion corrected, but you may have to have something done with the joint. And that could mean fusing the big toe or replacing the big toe, because, again, a lot of it is based upon how much arthritis is formed at the joint. But definitely can still have the Lapiplasty to correct the deformity that has probably formed again.
Okay, great. Thank you. So
Sure.
Another question that we've gotten a lot is how long until I can drive after having the Lapiplasty procedure done?
So 2 weeks, in my experience, is best to wait 2 weeks. And I always tell patients, especially if it's your right foot, because, 70% of the time we're doing the left foot, because a lot of patients, again, are active and they don't want to be down for any period of time. So the right foot, you cannot drive for 2 weeks, and it's usually just my recommendation because obviously there are other people driving. You don't want to get hurt. And if you have any sort of pain and have to slam on the brakes or anything that could cause an accident and you're too much in pain, it's probably more of a safety issue. And then as I tell patients, start out slow, go practice in a parking lot, your development or wherever, and just learn what it's going to feel like. And then normally with your boot on, when you're walking, you'll have to take the boot off and put a surgical shoe on for the right foot to drive in. And then the hassle is having to put the boot on when you get out of the car, put the shoe on when you get back in the car. But that's just right-footed surgery.
Great, thank you. Another question that has come in is talking about if I'm up on my feet all the time. So a lot of people have jobs that require them to be on their feet all day. How soon can those individuals return to work after undergoing a Lapiplasty procedure?
So with people returning to, a difficult job, I recently just had a patient who is a nurse who is on her feet 12 hours, had to go back. So she went back at about, and she had a couple more procedures besides the Lapiplasty on her foot, as she was one of our study patients. But she went back to work at 8 weeks, is probably about the right time when I think that a patient can return where they're out of the boot, they're able to stand on their foot. She did have to return at a limited time, so more of 8 hours instead of the full 12 hours. And now she's at 4 months and she is returning to a full 12-hour schedule. But I think if you can do an 8-hour schedule, it's usually around the 2 month, probably closer to 3 months to really feel like you've turned the corner. But again, that's for patients who really stand all day. So you're looking at that 2 to 3 month mark.
Similar to being on your feet all the time, how soon will I be able to return to physical activities, including the gym or outdoor sporting events?
Sure. So I would think that when it comes to going back to working out, because I'm definitely a proponent of that for my patients and health and well-being, is that usually if you want to get back to doing anything, I've had patients ride a bike without having to go up out of the saddle with those type of bikes, can sit on the bike in their boot. I think they can do that as early as 3 weeks if they feel comfortable. And that's the benefit of going to physical therapy and learning what they can and can't do at the same time through our protocol. So 3 weeks of riding in their boot or their surgical shoe on a bike is fine. And again, upper body activity with weights and that type of thing is good if you're sitting, not necessarily standing and loading into the foot. But full activity, walking for recreation is 8 weeks. Once you can get yourself into a shoe, and then again, running and high impact is going to be closer to that 12 to 16 week mark. And that's just based upon your x-rays and your pain and swelling. And if it's really controlled and you've done well afterwards, you can usually get back to full activity at that point is 3 to 4 months.
Regarding pain, what does the level of pain and discomfort post-procedure look like, and is it different for each patient?
It's definitely different for each patient. When I first started, I had a patient who I did a bunion that told me it was worse than childbirth, and other people told me they just took Advil. Now, most people have been able to take a few pain medications. Their worst day is usually the day after the block wears off, but they need to start taking medicine ahead of time. A lot of people have been able to control it pretty well. I think that if you had the procedure on a Friday, for instance, I think by Monday or Tuesday, most people are all done taking any type of heavy pain medication if they need it. I haven't had anyone have to go to the emergency room after surgery. Most people, if they follow through with just the strict elevation, icing, that type of thing, most people can get through it pretty well. So by 3 to 4 days, they're pretty much done taking a narcotic pain pill if need be, or like I said, hopefully they're just doing ibuprofen and Tylenol at that point. And so I don't know. Most people have said it's usually around a 7 in the pain scale, but no one's ever said it's been as bad as old bunion surgery, if you will.
Great, thank you. So is there any way to truly correct a bunion without surgery?
Did you say without surgery? I'm sorry.
Yes.
In my experience, I don't think there's any way to correct a bunion without surgery. This is truly a surgical procedure due to the deformity and the unstable foundation of the joint. There are a lot of structures and devices out there to essentially relax the muscles around it. I've had people tape the toes or tape their metatarsals to try to recreate what the Lapiplasty would do. But our bodies are quite powerful. The muscles, the tendons, the minute we step down, things kind of go out of alignment. So it is really not a procedure. It is not a deformity that can be corrected without surgery. It's mainly just to get their pain down. And if you find ways that can control your pain without surgery, then that's the best way for you.
Great, thank you. Regarding the procedure, does the hardware from the Lapiplasty procedure need to be removed?
That's a great one. As I've been going over all of our procedures that we've done, and again, I think we're close to 290. And I would say, in my experience, I believe I've removed about maybe 8 patients have actually had to have hardware removed. A few were due to infection. Some were due to just a slow healing, or the pain was just too great. I had a lady that did one, and a year later, she just felt as though the pain was too uncomfortable. 9 days after we went back in, took out her hardware, she said, yep, that's the problem, and she felt amazing afterwards. So just with any hardware, as we try to make them even more streamlined, or the newer products that are out there that Trees has that are trying to make them so thin so that patients don't feel it, it's becoming less and less of me having to remove hardware. But again, it's just based upon how patients there aren't a lot of fat on the top of their feet, and that does create issues. But once the hardware has done its job, it's not really mandated to keep it in there. And some people don't like the hardware in there to begin with. They don't want things in their feet. So it's not the first thing I do, that's for sure. Of all the ones we've done, like I said, out of 200 some, I've only had to remove 8, maybe 9 patients. So it's not high on the list, but if it has to be done, it has to be done.
Thank you for that great elaboration. Another question that has come through is, do patients typically lose flexibility in their feet or their toes after the surgery?
If we're working on just the Lapiplasty, I think a lot of patients have had to get used to how it may feel. The words they use are stiff, or it feels more solid than the other foot. I mean, you are working in a joint that used to be what we call hypermobile or unstable, and we're essentially creating it to become stable. The largest thing I see is patients have slight arch pain for a little bit of time after the surgery, but this is what physical therapy and orthotics or great fitting shoes and arch supports that do need to be done to let that calm down. But the toes should have a great range of motion. That's the best part about doing this procedure at the joint that's behind the front part of the foot, is that people can go back to wearing their heels. People can go back to wearing any type of shoe with a wedge, or any type of shoe, a flat, or whatever it is, and their big toe will still move with the same range of motion, since we're really not ever violating that joint. So the only thing you'd feel is really in the middle of the arch. People have to kind of get used to how a joint used to move a little bit more, and now it moves a little bit less. But that's all I see.
Speaking of shoes, are bunions caused by improper shoes?
I think there was a reason behind it at some point that I think people had to throw it out there and say, oh, and there are still some of my patients that have come in and say, oh, well, I wore high heels all my life and I worked in that type of industry and I gave myself this bunion. Well, but you don't have the bunion on the other foot. You know, you may have it on just the one foot. So it's hard to think that if a person comes in and they have one foot with a terrible bunion and the other one is completely normal, and yet they wore the same shoe on both feet, I think it's hard to really say that it's really shoe gear. So more and more studies have shown that it's really related to biomechanical changes in people's feet, which really goes back to being congenital or more of a genetic type of thing versus shoe gear.
Great, thank you. Another question that has come through from a couple patients is, I have a hammer toe as well as a bunion. Can I have that corrected at the same time as undergoing the Lapiplasty procedure?
That's a great question. Normally, we try to do everything all at once. If there is a time that we have to do stage procedures, but hammer toes are definitely a need. You know, I always go into it and say the Lapiplasty is going to be the easiest thing to correct. The hammer toe is going to be the more difficult thing to correct. It is not that it's challenging, it's just expectations. You know, we have a crooked toe, a bent toe. In order to correct that, a lot of times that means that we have to essentially put something in that toe to keep it straight. That usually means a small screw. That could mean a pin. I've gone away from using pins a lot, just with patients not wanting to have pins removed out the tips of their toes anymore. But in essence, they go from a toe that bends to a toe that's not going to bend at the joint. But yes, you can fix all hammer toes. We'll fix any other neuromas or pinched nerves if we need to. We'll do as much as we can without having to create too many incisions that could create problems with slow healing. But if need be, we can do the Lapiplasty and all four toe or all the lesser toes or all four toes at the same time as well.
Great, thank you. Another question that has come through is, can you perform a Lapiplasty procedure to correct a tailor's bunion?
So that's been another thing that we want to be able to look at that. The most difficult problem with the tailor's bunion is that is a joint at the fifth tarsal metatarsal joint, which we place a lot of pressure into the outside part of our foot when we walk. If you look at your foot in like the sand, you know, the main thing you're going to see is all the way around it, and the arch is going to be the one area that you don't see touch the sand unless you have a very flat foot. But that area on that fifth tarsal metatarsal joint, it should not be fused, which is essentially how we do a Lapiplasty of the tailor's bunion. So to this day, no, we don't do it on the tailor's bunion. We do have to do other type of osteotomies, but that tailor's bunion doesn't react like a first metatarsal does. So the chance of a tailor's bunion usually is way less of a reoccurrence than it was of doing the bunion on the inside of the foot, if that answers that question.
Yes, it does. So do you ever have to typically fuse the joint in the big toe?
I've kind of looked at it and said that anyone over the age of 65 who has had a bunion, there's a high probability of having joint arthritis, and I may end up fusing the joint on those patients. But again, it's really based upon if they have any joint pain. If a patient comes in, says, in my practice, if they have a bunion, and I ask them, is it just the bump that hurts? Is it the bottom of the foot? Or is it actually the joint? If you actually have joint pain, it wakes you up at night. We press on the actual joint. In that category, even though I'm going to still do the Lapiplasty, there's a chance that I would end up having to fuse that joint or replace that joint, because even fixing the Lapiplasty or fixing the bunion with the Lapiplasty, I didn't fix any part of that joint, and I guarantee they'd wake up, love how their foot looks, but still not like how much pain they have in that joint. So, and even I myself have a big toe that's fused. I still golf, I still run, I still play pickleball, and it's really probably the best thing I've done just to correct my arthritis. But if anyone has joint pain, it's probably best to have that fused or replaced in order to finally get the pain that they've had for a long time.
Noted. Thank you. Another question regarding the Lapiplasty procedure that has come in is, will I have a scar after the procedure? And if so, how big is that scar going to be?
Good question. And again, a lot of doctors, surgeons who do it, everyone probably does it a very similar way. The majority of scars or incisions are going to be about 5 centimeters. In our practice now, we've really moved over to just a very small incision of 2 centimeters, which you can kind of guess that's probably like 2 pinky nails, in size. If you put them together, that's about 2 centimeters. So we're trying to keep that very minimal. So if you can put the 2 words nice scar in the same sentence, as we know, all scars are a scar, but normally we try to keep them very nice, if you will, afterwards, or smooth. So there's a lot that goes along with it, definitely healing properly. So you will have probably 3 incisions, one where the tarsal metatarsal joint is, one by the big toe where we do a release, and then the other one is where the jig gets placed, but those are very small incisions. So most people have minimal scarring problems unless they have some slow healing, and hopefully over a year. Scars mature after 1 year, so after a year, that's about what the scar is going to look like. So if you work on it with vitamin E or other types of things, a lot of times we can get the scar down to where it looks minimal at best.
Okay, great. Thank you. We have time for a couple more questions. So another question that has come through is, I live in a 2-story house. How should I plan to get up and down the stairs? Can I walk up the stairs, or should I plan to stay on the first floor for some time?
That's great. There are people will figure out. I mean, in a way, they'll end up making their first floor bedroom, just as long as there's a bathroom, as long as they're close to food, whatever they might need. So some people stay on the first floor, but normally, if you do have to be that minimal weight bearing, non-weight bearing, I'd like you to be for that first week. I know that a few steps up the stairs on your heel and your boot is probably okay. But in a perfect world, I usually tell people they probably have to go up on their backside all the way up the stairs, and then usually tell them to try to have a knee scooter in the first floor and maybe a walker upstairs. But if you do have to put a little pressure on your heel and your boot, it's okay. I just don't want you to have to stroll around the house all day like that. But normally, if you can go up the stairs, it's 1 step at a time with your boot. If it's too wide on the stairs with the boot, it's probably best to go up your backside, scoot up the stairs, and then you do have to get up to your feet when you get up the stairs. But it is a tough thing to be non-weight bearing, or at least minimal weight bearing. But we always try to make it work for everyone who can get through the procedure without having to really be completely off their foot just to get up the stairs.
So if I live alone, do you recommend that I have someone come and stay with me for the first couple of days post-procedure?
Yes, I think for safety reasons with anesthesia is the number one. We just don't know how people are going to react. You know, there's this medicine Versed that it can really make you in a fog, especially based upon our ages. If we get a little older, it does take a while for the anesthesia to leave our system. I always think it's best to have some sort of family member, companion for at least the first couple of days. And then to really, get yourself situated, kind of learn what it's like to get around, see if you can do it on your own. We aren't sending a lot of people to skilled nursing facilities after this type of procedure unless you really are home alone, have no help, and maybe it's best for your own safety that we send you to a facility like that. But 95% of the time, or maybe even 99% of the time, we're making people, they're fine to go home. But yes, I always think it's best to have someone with you for those first couple of days.
Great, thank you. Another question that has come through is, I'm currently taking a weight loss drug. Do I need to stop taking this drug to have the procedure done, or can I still take it and undergo the Lapiplasty procedure?
The biggest thing that's come out with anesthesia now, which relates to these drugs, the Ozempic, the Mounjaro, or the semaglutide, or those other ones, is that it slows down your gastric emptying, which is the big part of, if you imagine when you have surgery, you're supposed to be NPO or not have anything to eat after midnight, right? That's for 8 hours or 12 hours before your surgery, right? So with those type of medicines, the weight loss medications or injections, is that it slows your gastric saliva and those other juices, if you will, that create problems with anesthesia as they're starting to move forward on that. So anesthesia has had people stop that injection probably a week ahead of time just so that it doesn't create those problems with gastric emptying. So that is the new thing out there, that anesthesia. Obviously, it's best to talk to an anesthesiologist before this, but that's what I've been seeing in our practice, and those patients who are on that, they need to stop it at least a week before.
Regarding the procedure, how long does a typical Lapiplasty procedure take, and how long does it take for a patient to be discharged from the doctor's office or the office where the procedure was undergone?
Where they're having it done, like at the hospital or surgery center. So patients usually have to be there before surgery about 2 hours before. So if your surgery is at 7:30, you have to be there probably 5:30, 6 o'clock, as they have to get you registered, IV put in, and then anesthesia does their block. So usually for straightforward Lapiplasty with no other procedures, we can usually get it done from beginning to end in about 45 minutes or less based upon your deformity. So getting in the room, so let's say an hour for the entire procedure, but really the procedure itself from tourniquet time, start and end, closure and everything is about 40 to 45 minutes in my hands. And then usually you go back to the post-op care unit. A lot of patients, if they're just under sedation, local with sedation, they'll wake up pretty quickly. A lot of times they could be out of the hospital or out of the surgery center closer to probably that 10:30 time. Again, surgery centers do move a little bit quicker than hospitals. Hospitals definitely are busier, sometimes understaffed, and they have a few number of patients, so it does take them a little bit to get the patient back to the same day. But let's say your entire time there from, say, 6 a.m. to maybe 10:30, so it's about 4.5 hours if you're really just having the Lapiplasty done, and that's about your entire time there.
We briefly talked about physical therapy, and you are a big proponent of having your patients undergo physical therapy post-procedure. If their doctors do not recommend or give them a name of a physical therapy place to go, what can you typically provide your patients with to kind of get them in the right track, getting back to those everyday activities that they love?
Sure. So I used to not even do physical therapy in the beginning because I always thought they're just walking, they're fine, everything's going to be good. But what happens is you're in the boot for 6 weeks. You've kind of slow down your muscle activity. You've kind of immobilized them. Their calf muscle's not the same, their ankle. So it's not even really the foot becomes a problem, it's their ankle. So a lot of the activities we'll tell them is definitely ankle range of motion early on. I have them start moving the ankle up and down. Circles are fine, alphabet circles with the ankles. So it's all about getting range of motion. And then once the incisions are healed, I have them start moving their big toe around, whether it be with their own hand, kind of move it up and down, try to flex it up and down. And then if they can't get into therapy early, that's okay. But if we start to see the patients in my practice have trouble walking, they really just aren't doing normal gait, at least by 6 weeks, I do, really stress them to try to get going into some sort of home therapy or even their own therapy modalities. But really, it's all about range of motion, flexibility, and then massage for themselves to really get that arch pain to kind of go away in the beginning. So, if they don't do therapy, it's okay. It's just that I just am a proponent of it because I've seen too many patients that really, who didn't do it, who struggle with it in the end, and it's 6 months later and they're wondering why their ankle's still sore or other things like that. So.
I know we talked about this a little bit earlier, but I wanted to kind of reiterate, how does a doctor, or in your experience, how do you determine if a patient is an ideal candidate for the Lapiplasty procedure?
So the only thing that, from my standpoint, looking at things in my practice is definitely, number one, most patients who have bunions are probably very active. They're usually healthy patients, but there are patients who are, diabetic, who do smoke. We definitely try to, tell the patients to limit most of those things, get them under good blood sugar control with their doctor before they end up having elective procedures. But anyone with an increased angle of a metatarsal away from a second metatarsal is a candidate. Minimal arthritis or even moderate arthritis are a candidate. Those patients who can undergo the procedure, who understand anesthesia, who don't have issues with anesthesia, and can really understand to be able to get through the post-op protocol. And again, those who really have pain when they come in and kind of understand that they want their bunion corrected. So a candidate really is those with a bunion, with the minimal or moderate arthritis, and again, those that can go through a surgical procedure and recovery course without too much difficulty.
So how does a patient go about scheduling an initial consultation to get more information from their doctor?
So first off, I know a lot of people may be using the Align My Toe or the Lapiplasty.com site. I mean, I have actually, the one thing is I've actually been getting to our practice is that a person from the website or from Treese is actually almost initializing this conversation sometimes, where they will call our office with the patient on the line, and we'll have a 3-way call with my manager or my staff, and definitely make sure that they're going to get the surgeon who does the Lapiplasty. So obviously you want to find the surgeon who does it. You try to, I don't know how often people look at how many have been performed, but definitely you want a reputable doctor who's done it, who does it on a regular basis. But normally you call, get set up, and then from there, do your research, do what you can to know more about the procedure, talk to that doctor about the different, ways that are done, the 3D correction, that type of thing, and just make sure that you're getting what you really want, which is, the true Lapiplasty procedure. So getting in there, having the surgical consultation, make sure x-rays are done, and that you just feel, really comfortable with everything after the consultation.
I'm interested in setting up an appointment. How can I request an appointment with a doctor in my area?
So, I think that going through, and I've not been on the website in a while, but I believe that Lapiplasty.com can steer you. You find the doctor in your area, put in your zip code, area code, look for how many miles away. I literally had a patient from Arizona who came out to see me. Actually, it was New Mexico, whose doctor was going to be 3 hours away from her. There was no way she was going to drive out there and have surgery and have to drive back for 3 hours or stay at a hotel. So she flew out to Ohio, where her family was, and found me. I was only 40 minutes from where she lived. So really it's all about finding the doctor locator, looking online, getting them scheduled at that point, making a phone call to the office, and really that's how it really moves forward. If you do have any questions, there are people on the website that you can actually call. Like I said, they can facilitate that and actually set it up with you on the phone to make sure you're getting who you need to see.
Great. Thank you, Dr. Togan.
You're welcome.
As we begin to wrap now, if your question did not get answered or think of something later that you wish you'd asked, feel free to reach out to us. Our email address is patientinfo@treece.net. You can also learn more or find a local doctor by visiting our patient website, which is lapiplasty.com. Don't forget that as a follow-up, we will email all registrants an archived webinar link for reference. We hope you found the information presented tonight helpful. Dr. Togan and I appreciate you joining us this evening. Have a great rest of your night.
Thank you. Take care.